Welcome back, everyone. If we could all reassemble, and I'm delighted to see people wanting to stay healthy, and for our next panel to discuss a particular issue that the world, of course, is facing, that as populations age and the burden of disease changes, we're seeing major sort of demographic shifts very much increasing the demand for healthcare in particular areas. And this is putting great pressure on financial resources, a real headache for governments as to what to prioritise. So in this next session, we are looking at the growing demand for health services from ageing populations and where the pressures are, and what's going to be the best way to tackle these demographic shifts as populations age, and thinking particularly about the growing burden of non-communicable diseases that is affecting the world. We're very keen in this session to be as interactive as possible. We're going to have some introductory remarks from our very eminent panel now, but we also want to be taking questions from the audience, and we're going to do some polling as well in this session. We recognise that not everyone is sort of from a health background here, and we want to sort of get the views as much as possible from this broad spectrum of stakeholders as to what do you think are the major priorities going forward. So our online audience, I think, is being sort of presented at the moment with some sort of polling questions, and I think delegates are aware that if you use the QR code on the back of your program, and I think most people have already logged into the conference portal, you'll be able to access this poll yourselves. So before I introduce our eminent panel, I'd like to sort of put the first polling question to the audience, which I think I have just in front of me here. Yeah. So, thinking about aging societies and the way that the world is changing, what do you see as sort of the major health challenge facing an aging society? And the three sort of options, and there's no right answer to this. It's not as we're going to sort of show you a global burden of disease study and show you who was right and who was wrong. But in your perceptions, and this might be your own personal experiences or your family's experiences, do you see the greatest health challenge being cancer, cardiovascular disease, or Alzheimer's disease? So you have a sort of a choice of three there, and I think at some point we'll give people time to answer those questions, and at some point hopefully the results are going to pop up on my screen, although they're coming up already, and we'll be able to relay those to the audience. But to get the discussion going, I'm going to introduce our very eminent panel, who are going to give us their introductory remarks today. We have two with us here on stage, and two joining us virtually. Unfortunately, Professor Ilona Kickbusch wasn't able to join us, but David Taylor, very much at the last moment, has agreed to participate in the panel, and is a great expert on these areas, so we're delighted to have David with us. But with me as well on the stage, and who's going to start off with us, we have Louise Houston, who is Senior Vice President at MSD and in charge of the Global Market Access Program at MSD. Next, I think we're going to be having joining us Santiago Calvo Ramos, who is a health economist and works for the Economic and Financial Affairs Department at the European Commission. I think, are you speaking to us from Brussels today?
I am, yeah.
From Brussels, marvellous. So joining us from Brussels, and Professor David Taylor we'll be going to third, who is an emeritus professor at UCL in pharmacology. Oh no, sorry, David.
Pharmaceutical and public health policy.
There you go. Thank you. Terribly sorry, Dave. I lost the little piece of paper that you gave me earlier, I'm afraid. But also has been a chair of various NHS boards for the last 30 years and extremely knowledgeable about the NHS system. And finally, we have André Ilbawi joining us, who's the Cancer Control Officer for the World Health Organization, who made heroic efforts to join us here in person, travelling from Lebanon to Geneva, but then the travel chaos in Europe failed to bring him to us today, but very gallantly is joining us online from Geneva, I believe. Thank you, André. So if I may turn to you first, Louise, what are your perspectives about the demographic shift, the pressures building on health systems, where we should be prioritising going forward?
Yeah, thank you, and wonderful to be here today. So, as you explained, my name's Louise Houston. I'm the head of global market access for MSD. So, large pharmaceutical company, and we operate in over 60, 70 markets globally. So I think we have a perspective of lots of different healthcare systems that we see. And, we have the privilege of speaking to many payers and governments around the world around the issues they face with healthcare. And this issue of aging is something that's kind of perplexing all of them, irrespective of income level, obviously more acute in some than others. So delighted to be here as part of this panel and really looking forward to the conversation. And actually very many parallels, I think, to the prior conversation around universal health coverage, because if we are going to have healthy aging, then we need a very early prevention agenda. And to live well and live a long and healthy life means that we have to educate early, we have to have prevention activities early, we need to diagnose early, and we need to treat early. And so I think, really thinking about how we can reform healthcare systems is going to be very important to enable that to happen. I think from our perspective, and maybe I'm jumping ahead of your poll, but I think cancer is going to be something that we really have to look to address as societies age. We know it impacts probably 1 in 2. Predominantly it's a disease of the over 65s, and so really thinking about how we can address that moving forward is going to be really important. And so I think there's an urgency there, but I also think there's a real opportunity there because of the advances that we're seeing in science, which isn't necessarily the same with something like Alzheimer's, unfortunately, and other neurological conditions. I wish there were. My dad suffers from Parkinson's, and I'd love some new treatments. There haven't been many for years. But in terms of cancer, I think we are now starting to see some political will coming to say, actually, we could do something and we need to do something. So if you take the Europe Beating Cancer Plan as an example, it was launched in 2021. And it really is a political commitment to tackle the entire disease pathway. So prevention, early detection, diagnosis, treatment, and quality of life, which is really important. And I think with cancer, the other element is survivorship. Because of the treatments and the innovations that are now coming through, we are having patients living longer, but having to think about patients surviving having had cancer, which is really important. Linked to that, which I think is something all health systems will need to think about, is health coaching. Because we are now able to, in some instances, predict who might suffer from certain diseases. We can detect early, but what patients do with that information, how they respond to it, is going to require, I think, a degree of health coaching to make our systems and our population more accountable for their own health. And, I guess it links into health literacy as well, but you need to understand as an individual how to access treatment, what a diagnosis means, what you can do yourself to stay well, and when to access the healthcare system. So I think health coaching is something that many systems might have to think of. But I think cancer is just a great example of how we could make a big difference and help patients live longer. And in part, as I mentioned, that is because of the scientific breakthroughs. So we now have the potential for liquid biopsies, so you can diagnose very early. For some cancers, not all sadly, but there are really great screening programs that you can have in place. And then with early diagnosis, there are now many innovations that can allow for early treatment. And we know if you treat early, you're going to increase the likelihood of disease-free survival for these patients and enable them to live long and healthy lives. So I'm really curious to see what the poll says, but I think for cancer, there's both the need, but also the urgency as well, and the opportunity to do something.
Yeah. Well, I can actually tell you, I'll cut straight to the chase. I feel like the returning officer here, but cancer, 48%, cardiovascular disease 39%, and Alzheimer's 13%. So interesting that in the poll, it was roughly half the audience actually thought that cancer is the biggest threat, so which is very interesting. So Santiago, if I can come to you as a health economist, looking at these issues and how are European health systems sort of building themselves up to become resilient to these changes. What's your perspective on these priorities and how we should best respond to them?
Mm-hmm. I think these are real issues, and of course non-communicable diseases and cancer are really affected by aging. So I think those are really key factors. So to introduce myself, I work in the Unit C2 of DG ECFIN, and my role is to assess the long-term fiscal sustainability of European health systems, and then to suggest policies that might actually help them become more efficient. So due to the COVID pandemic, health systems have rightly focused on effectiveness, accessibility and quality over the last couple of years. However, it's also true that over the longer run, we expect the aging of the population, as well as technological progress, to lead to increased healthcare expenditure. And this could challenge fiscal sustainability, which is the ability of governments to finance their own actions or the policies in a sustainable way without recurring to ever-increasing debt. So the population in European countries is expected to age significantly in the next 50 years as life expectancy increases. So in a sense, this is a success that also has costs and that we need to tackle if we really want to capture the benefits of this success. And at the same time, new treatments and technologies that support this expansion of life expectancy are also likely to have a significant cost. So this means that we expect healthcare expenditure to increase in the next 50 years. Increased demand, increased ability to treat conditions, and we publish every 3 years together with EU member states our aging report, where we project expenditure on healthcare and other age-related items up to 2070, so for the next 50 years, more or less. We then complement this with projections of economic growth, so we see how much we will need to spend, we see how much income we will have, and then also with projections of the level of debt of each country, so that we know how much we owe already. And bringing the three together, we are able to see which countries can have trouble in terms of financing this increase in expenditure. And indeed, our findings are that some of them may have these problems. So in that case, what we do is that we recommend, we could easily recommend to cut healthcare expenditure, but this would be completely counterproductive. We wouldn't be able to harvest this success of increased life expectancy. It would have a huge human cost. So basically, that's a very, very bad idea. So basically, we're trying to identify reforms that can increase the efficiency of healthcare systems. And then we're trying to recommend this to member states through our European semester, recommendations that we give to the member states every year, and also through the new Resilience and Recovery Fund projects. And so when I talk about improving efficiency, because this is always said in a very vague way, so to try to put a bit of meat on that, we're thinking about things such as effective budgeting, governance and control, so ensuring that budgets are realistic and are met, emphasizing primary care, because primary care often helps educate patients, as the previous speaker was saying, and it also helps manage people so that their diseases actually do not progress. So this can be, of course, help with screening, but also help with managing something like diabetes, where someone with diabetes shouldn't need to actually go to hospital because of the diabetes, if they are well managed by the GP, let's say. And so investing in primary care is something that can really help both the health status of the individual, but also be more efficient in terms of the use of resources. And we're also thinking, just to say quickly, things like integrated care across different parts of the healthcare system, but also with long-term care, which is a very important sister area, increasing the efficiency of hospital care, using the operations where possible, benchmarking performance, because it's very difficult to know how well you're doing unless you compare yourself to others, both nationally and internationally. Prioritizing public health interventions, prevention, improving health behaviors, of course, cost-effective purchasing of pharmaceuticals and medical supplies. We live in an age of amazing technological progress in that area. And health systems need to be ensured that they purchase these items in a cost-effective manner. And then workforce planning, which is one of the big cost drivers, and where you need to actively and, well, proactively manage the numbers that you have of different specialties of medical staff, so that then you can actually provide care effectively. So just to summarize, aging is certainly going to increase demand for care and will require additional efficiency and reforms in healthcare systems so that we can benefit from the increase in life expectancy in a sustainable way in the long term.
Yeah. Fantastic, André. Very, very important emphasising this in improving efficiency. And we heard it in the previous panel, Ilona saying, you know, how important this was to persuade the Ministry of Finance to increase financing to the health sector in Ukraine, and of course tackling corruption being a very good way to improve efficiency as well. If I can come to David now. David, we've been sort of chatting for years about improving efficiency in health sectors. What's your thoughts about ageing populations and us getting sort of the balance right and attacking these priorities in a sensible way?
Thank you, Rob. The process of demographic transition, which in this country has happened from about 1750 to date, about a quarter of a millennium, is the gradual process where infant mortality falls, life expectancy increases, birth rates fall. The reason populations age is not really falling death rates, it's falling birth rates to get that structural change. And with it, you get changes in the pattern of disease. You survive infectious disease in infanthood. You move on to experience heart disease in middle life, cancers, as I've had in middle to later life, and the neurological diseases. So it's like peeling an onion. First of all, you deal with the infections. And of course, improving health, as we've heard, is not just about healthcare and medicines. It's about education. What's the strongest correlate with infant mortality? It's maternal education. It's about general production. What happened in England was that we had industrialization, we changed agriculture, we were able to import food from North America. That benefited young people like you, not me, because their immune responses got better. So death rates fell. That's how we built an empire, because temporarily our population had expanded because the death rates amongst children fell, and we were relatively healthy. We could go out and invade the rest of the world. Hopefully we've stopped that now, although some old imperial powers clearly are having problems with changing that habit. So we've got that picture where, by and large, several things I've heard during this conference, which is brilliant, and of course, I call care transition the process of healthcare change which follows demographic transition, helps drive it, but also follows it. So your initiatives on universal care are part of what I call care transition. That's really what the serious part of my somewhat checkered career has been about. So what are the important things to say? What I disagreed with was the suggestion we haven't done well with COVID. Worldwide, compared with any other pandemic of it in history, we've done stunningly well. Yes, there have been delays in addressing Africa, although remember, Africa, sub-Saharan Africa, what's the age structure? 5% of the population aged over 65, i.e. 10 years younger than me. The relative risk's different, and the technology's building. I think the real story, and I sometimes worry about politicians and others, I'm trying to pick my words carefully. The real heroes in this, of course, have been BioNTech in Germany, Pfizer in the States, Moderna in the States. It's their technologies which have saved the world. Relatively easy to distribute, but we haven't done that well, and it's the failure of politicians and healthcare systems. That's why I hear what, for me, is a lot of anti-industry bias. And if you were unwise enough to ask my advice, Rob, I'd say one of the things your commission should do is try hard to understand its prejudices, try hard to really understand the role of pharmaceuticals. In That first stage of transition after infectious disease, you've got the terrible problem with heart attacks, strokes, myocardial infarctions. The world has tools now which we can distribute even in poor settings. So low-dose antihypertensive combinations. Some doctors and pharmacologists will tell you combinations very bad. This is because they're not very good. They don't understand. You need to understand drug use. We could make statins antihypertensives, drugs like metformin for diabetes, much more widely available in Africa. In India, the world's biggest generics manufacturing, but an appalling story, really, of failure to supply to the poorest populations. We could do that, and we've got that tool. Cancer, more complicated. Fantastic, exciting developments. That temple over there, that big building, is a public sector testament to cancer research. We will have treatments which radically change survival. We already have. Breast cancer, for example, we've increased life expectancy with a diagnosis of breast cancer by about 20 years. Fantastic achievements. These will go on, but we face big problems in delivery in poor areas. These are complex technologies. What do you need to do? Well, first of all, you need to control smoking, of course. That's been one of the big drivers of our development in countries like the UK and the States. Africa's poor countries vulnerable at the moment to tobacco. Once we do that, what do we need to do? We need to be able to get early diagnosis, because the simplest thing is to cut these things out before they spread. Difficult to achieve. When you've got an established cancer, sophisticated medicines, we don't have really the equivalence of statins and antihypertensives, but we will get there. And the real challenge for the world is, how do we make those technologies available in poor countries? So if the pharmaceutical industry were unwise enough to ask my advice would be learn from Chatham House, set up your own commission and do it publicly about how we make those technologies available. And let's see the industry as a social actor. I think you're sometimes maligned, but prove them wrong. That's what I say.
Thank you very much indeed, Dave. That's fascinating. And I think you're describing these transitions, and I know that our commission is going to be looking a lot at access to NCD medicines as the front line, particularly in middle-income countries. You know, we heard it from Ilona talking about Ukraine. At the dinner last night, I was talking to someone, I'm not sure if she's here, that from Sri Lanka, and saying that, you know, that this is the big issue at the moment, access to NCD medicines, and sort of given the financial crisis in Sri Lanka. And most people returning to Sri Lanka now are going back with suitcases full of medicines for their families. So absolutely essential. So André, if I can turn to you finally, you're the experts on cancer. And you topped the poll with 48% of our respondents saying this is the biggest challenge. So how are you and how are WHO going to solve these problems?
Thanks, Rob. Just again to apologize for not being able to greet you in person. This is such an important topic, and thank you for giving visibility to cancer in the public health agenda. As Louise and others have said, in fact, cancer reflects the health of communities and our ability to deliver on universal health coverage. Because in fact, nearly one in two will develop cancer in their lifetime. It is also one of the most sensitive diseases to the aging of a population. In spite of this, as David just said, there are signs of success in high-income economies that have blunted the burden of cancer, particularly because of tobacco control. That has allowed us to be in a situation where the cancer burden in countries like the UK have increased only 10 or 20% over a 10-year period. 10 or 20%. Let's contrast that with the world around us, where aging is compounded by increasing risk factor prevalence and exposure. In Asia, as an example, or in Africa, a doubling of the cancer burden over the next decade. This will require a doubling of capacities in health systems that are already strained. But we are seeing signs of agitation. As we heard, the importance of civil society, that we can and should do more to ensure that cancer services are available and accessible. The current reality is that most people with cancer globally are paying out of pocket, and this is triggering generational impoverishment. What are we doing at WHO? What are we doing as a community now in light of this COVID-19 pandemic? As we heard from David, I agree, there surely have been signs of success in our response as a community. But let's also pause and hear what's happening at the individual level. More than 1 in 2 people have lost confidence in healthcare systems. This is a devastating status quo, a new status quo that we're going to have to work against, because it will influence how people choose to live and how they engage with their health professionals and with companies. In reality, this is a fractured relationship, and this was being further compounded by the economic strains and social unrest. But this is not an ominous message. There are reasons to be optimistic. As we've heard, and just to reiterate, we must invest more in people and communities. As you alluded to, Rob, there's a lot of discussion on access to services and technologies. This is indeed very relevant. But the overall largest expenditure are salaries for the cancer workforce. We must build a workforce and empower them to do more with less by effectively using technology and innovation. For too long, we have not been able to deliver on that, including the use of electronic medical records. The same is true for families affected by cancer. On average, with an aging population, we must think of caregivers. Caregivers provide support to their loved ones 8 hours per day for over a year. Yet in the OECD, only about 1 in 3 countries have paid family leave for someone with cancer. Unless we start by placing individuals and families at the center of our investments, we will not make progress, particularly in the setting of an aging population. Second, as you alluded to, let us build a retrust. Let us invest in relationships between sectors and across borders. Cancer, like COVID, has shown the benefits and the barriers to international collaboration. We can do more. As an example, the majority of people affected by cancer live in low and middle income countries, but do not have access to clinical trials. The same is true for access to clinical trials among the elderly and the poor. If we ignore populations, we lose trust in institutions. Meaningful international collaborations founded on trust and transparency can show the value of multilateralism and multi-sectoral partnerships, but we cannot ignore the neglected. And finally, solidarity. In the past 3 years, we have seen incredible solidarity in how communities have cared for each other during the pandemic, during the war in Ukraine, as we've heard. This is a powerful signal of the human spirit. This is the same solidarity that we must reactivate as we care for the aging and as we build systems responsive to their needs. Universal health coverage, as we've heard, is the only way forward, but the challenge is that it requires a view beyond the short term. And it also requires that people, communities, and societies embrace the uncertain. That is a lot to ask during difficult times, but indeed, together is the only way forward. Back to you, please, now.
Fantastic. Thank you very much indeed, André. And in fact, some of the points you were making there lead in very nicely to our second survey question. So if I can go straight to that. And as I ask this question, if you can be thinking of the questions you'd like to put to the panel now, that would be extremely grateful. I've got 1 or 2 coming online, but very keen to get the views of the audience here as well. So the question that we have now, and this is really about how you respond to these challenges, and André's already mentioned a couple of these. If we're looking at how health systems meet these challenges of changing health needs, what do you think is the most important thing we should be trying to do? Should it be stimulating health system innovation, that trying to become more innovative in tackling these problems? Is it basically just an issue of increasing financing, that we should be spending more and more on health systems? Or is it more to do with the demand side and empowering citizens, informing citizens, and perhaps more of a behaviour change approach? So I can see a lot of people are thinking, well, actually, it's all of those, really. But I'm going to try and put you on the spot a bit here, that if you could only do one, or you would prioritise one, what would that be of those things? So stimulating innovation, increasing funding, and empowering citizens. And people will be voting as we speak, and at some point I'll drop those into the into the conversations. So, do we have any... oh, terrific, excellent. This is always good for chairs to see lots of hands going up. Thank you very much. So, I'll start at the back with Tim, and then I'll go here, and then I'll go over there as well. So, and if you could be very brief, please, because we need to finish 10 to at the absolute latest.
Thanks very much for a stimulating panel. I'm Tim Benton from Chatham House. David mentioned tobacco cessation. What about other means of, I mean, you touched it in your survey question, preventative healthcare, in the sense of particularly better access to nutrition, better diets, reduction of the NCD risk in general as a means of dealing with the age transition.
Great. Thank you. Maybe if I take those, take three at a time, actually, and sorry, where was the... yes, please, thank you. Peter, isn't it?
Peter Davis, University of Auckland, New Zealand. Two things. Firstly, your survey. I think the third question should be, how do we keep people out of hospitals? And that is empowering individuals, but it's also empowering primary health care, which at present has been a poor cousin. The second question, the question I put is, with the demographic aging, what we're forgetting is a lot of older people may be free of physical illnesses, but we have the issue of dementia.
Yeah.
And there are no technological fixes for that. It requires upping social care. So in fact, we need a whole new workforce which is skilled in caring rather than in managing technological innovations.
Very, very good point, Peter. And I think this is something that's been sort of kicked down the road by many governments, this interaction of healthcare and social care and how that's financed. So something for the panel to discuss. And yes, the lady there, please.
Good morning. My name is Miriam Ilona. I'm a member of More Futures Conversation. About medical tourism, some countries, some political leaders in some countries, they go on medical tourism to, get themselves treated while neglecting their own healthcare systems back in their country. Do you think if a sort of limitation is placed on this, or can it be done to, aside financial limitation, if this can be controlled somehow so the rates of medical tourism would reduce? And secondly, a lot of startups are building healthcare software applications to help people reach doctors quickly and chat to doctors about their symptoms and not really have to go to the hospital if it can be avoided. So can solutions like this be applied to primary healthcare, so to reduce queuing systems and,
Great, thank you. Was there any particular country you were sort of thinking about in terms of the medical tourism? Is it sort of a particular country that...
Okay, I'm from Nigeria. So.
Great, thank you very much indeed. So if I can put those questions to the panelists, and you might sort of pick or choose which ones of those you want to deal with, and hopefully we'll get them all covered. Louise, if I can come to you first, please.
Yeah, I think there's been conversation for years about shifting services into primary care. I think data is going to be so important in this moving forwards. And we talk about investment in health, but I think investment in health IT could be really transformational, because you then could identify those patients that, I think the NHS has successfully utilised data to understand, there's a very small proportion of patients that utilise a very high proportion of care. And if you can identify those patients, intervene early, then you can save yourself a lot of resources. I think the same is true across all elements of the healthcare system. So the use of data and IT to drive efficiency could play a huge role in all of the areas that we talk about. Who needs more coaching, who needs prevention, who needs support with nutrition, who are overutilising some services and underutilising other services. And then even within a country, you see disparity. So data to enable providers to compare how they're performing and how geographies are performing. So I think going to be an interesting discussion about the role of healthcare data to try and solve some of these issues. I'm not an expert in medical tourism, so I'm not going to go there. I think there's other people better and able to discuss that one.
Okay, first question about prevention. Smoking is obviously huge. We know there are dietary links to obviously heart disease, to cancer to a degree, even like alcohol. I often think I'm poisoning myself, but only 4% of cancers are alcohol linked, so we mustn't exaggerate these things. But they are all obviously important, and it depends on social structures, education, nudging behaviours, and also, where appropriate, legislation. Difficult areas, Helen mentioned pain relief earlier on. You've got the example in the States of over-free access to opiates causing desperate damage. You can have over-regulation as well, so balancing out. On the question of healthcare, I hear the need for primary care, but there's also a need for hospitals. I think in the UK, perhaps I gratuitously insult health economics, that health economics is a very good toolkit for making year-on-year allocation decisions, but it's useless for informing long-term policy. The people who've done it are, again, not very good and don't admit the limitations often of their toolkit. So we probably have underinvested in hospital places as well. We've also done a three-card trick on social care. The holy cow of the NHS was very good at making people feel they were safe. What we used it to do was cover up the fact that, compared with other European countries, we woefully underinvested in social care and reduced people to poverty before they had access to social care. So there are all sorts of things where the complications of politics and the naivety and limitations of most public debate hide things up. On medical tourism, if medical tourism is bringing resources into a country which are fairly spread and add to the country's wealth, then, provided they're not going and harvesting organs from innocent children, there may be a case for it. But you raise a broader question about this process of demographic transition. As you move from a situation where women have to keep on having babies throughout their fertile period just to keep the population stable because of the high infant mortality, the status of women changes in society. That changes their relationship with men. You get less need for patriarchal religions, patriarchal management systems. As you get smaller families, the risk of children dying is underlying that. But at the same time, if you do only have one or two children, then if one of them dies, it's a disaster. So you get much more male and female focus on child survival, and that changes structures. The emergence of universal health care is related to that underlying demographic and social dynamic, which we need to understand well. And obviously through the development process, or like the development of new treatments for cancers, it's a bloody, ruthless process. Many die sadly. Many die sadly in the process of healthcare and social development. But we will get there, and it's a belief in it and a belief in being rational rather than doctrinaire. That's another thing which changes gradually as we become more secure in the world. When you're in a desperate circumstances like isolated clans in Afghanistan, your values are centered very much on the people immediately around you. As you grow safe in the world, you can afford to think on a national basis and an international basis, and you can afford reason. Humanity can only tolerate a little amount of reality, but the safer we are, the more the reality and the reason we can tolerate, the more we can shift away from blind religious faith to reasonable, rational approach, and that applies in health policy as well. It's a hard message, but it's the one I believe in.
You bring up some interesting issues there, David, and one wonders just how successful we have been, though. In the international solidarity in tackling COVID. It was sort of there undoubtedly have been sort of big expectations that world would have performed better, but objectively you look at the misallocation of some of these resources, and unfortunately we haven't been successful. I just want to turn to the answers of that before I bring in our online participants to give you the scores on the doors when it comes to the last quiz, or the last poll, and in fact it's very evenly split actually. So innovation with 38%, increased financing 29%, and empowering citizens 33%, which I think really rings true really, that what we're really saying, it's all those things, isn't it? What I might do actually, because we're very keen to ask all the questions, so if I pose the next one now, so we don't run out of time at the end of this, but thinking about the big systemic changes, you know, the really radical changes that perhaps we're looking at in our commission, what do we think are the things that really are the most important there? Is it political commitment? And we've heard people talking about involving heads of state even involved in this. Is it a financing issue again, or are we basically just talking about increasing financing? Is it about reducing inequalities? Or what we're saying is that the resources are really enough, and if they were just shared out better, that would be the best way? Or is it more in terms of international solidarity, perhaps looking at reducing inequalities between countries as opposed to within countries? So again, if we can vote on those, and I accept that some of those may not be mutually exclusive, we're just interested to hear your priorities. But if I can turn to our online participants and panelists to reflect on the questions we've been posed so far. So I don't know which one wants to go first. So maybe André first this time.
Thanks so much, Rob. Really great questions. I'll try to do a rapid overview of a few. On preventative health services, absolutely. Tobacco is a success in Europe, but in reality, in most places in the world, it remains a scourge. This is really a challenge for us. Other risk factors, alcohol, you're absolutely right, David, it's only about 5 to 8%, but that's not inconsequential. Infectious, 13%, major progress because of vaccination. In fact, the mRNA vaccine that we talk about now, only about in the COVID environment, was a contribution from the cancer community that invested in vaccines. So we have made major progress because of vaccines in cancer in particular. Medical tourism, it goes to the point, yes, the business model may be compelling, but the inequities are profound. In a neighboring country from Nigeria, 1% of the population with cancer goes abroad. They absorb almost 50% of the health budget for cancer. So let us come to that reality and also acknowledge that in most of these countries, most of the workforce is also leaving. 37% of oncology providers in the US are international graduates. So we, again, are looking at short-term perspectives. How do we make long-term decisions that really emphasize the communal good? One brief question that we didn't touch too much on that I just want to raise in the setting of aging. It is really causing us to reevaluate, how do we define success? Success for so long has been, can we achieve the highest life expectancy in a community? We need to take a step back and start asking, what are our parameters of success? Is it longevity? Is it inequalities? Is it quality of life? And then how do we measure progress in the health sector against that? Because the current narrative is, well, everything for everyone. Let's have everyone live as long as possible, but the community is no longer asking us for that. If we aren't responsive to the needs of communities, then again, we will lose trust in the institutions related in healthcare. So I do think we need a broader public discourse on how do we measure success, because that concept of value is changing very rapidly now.
Mm-hmm. Thank you. Thank you very much indeed. Santiago.
Okay, yes, I'll answer some of the questions that I think haven't been touched on that much. Yeah, in terms of preventative factors, I do think that diet and nutrition are very, very important. They're difficult to tackle because they always wound up with culture, with national culture, and with socioeconomic conditions. And we don't even have very good data if we want to compare how healthy is the diet of country A with country B. So I think that's one of the items that we really need to tackle and we need to get more into, because I think that has a lot of potential. In terms of the issue of dementia, I agree that is a key topic. I mean, I should add that precisely diet can actually certainly help with something like vascular dementia. So it has, there's something that we can do in terms of prevention there, even though not as much as in other fields. And this really takes us to social care and the importance of social care. And I would say that really to have an efficient healthcare system, you kind of need to have a good social care system, because it really supports it very much, and it prevents the healthcare system from having to give very inefficient long-term care in the cases where there is no other the solution, as well as, of course, in some cases, the impoverishing of individuals, like David said. And then, in terms of solutions for telehealth, for primary health, for primary care, and together with the question about how to keep people out of hospitals, I think that certainly technology has a lot of potential, like Louise said, because it's really, if you know the patient pathway in detail, you can know actually what went wrong or what went well in specific cases, where the person that comes with diabetes complications to a hospital, were they unable to contact their GP? Did the GP give them the wrong advice? Or, we can, as a health system, we can really know what's going well and what's going wrongly. And similarly, telehealth can also be very, very helpful. However, for both types of expenditure, I think health systems need to learn how to fund them, because our funding is based very much on pharmaceuticals, and we're good at assessing whether they're cost-effective or not. But sometimes with new technological solutions, our old ways of funding may be antiquated, and we may not be assessing these new technologies correctly. So those would be my answers. Thank you.
Fantastic. Thank you very much indeed, Santiago. I'm just hoping that the final poll results are going to be coming in, unless I've missed them. Unfortunately, I think it might be a bit. We were talking about technology. I think it's just let us down a bit on the final poll. But I would suspect, sort of given the previous one, again, we are sort of looking at it being a sort of a combination of these things, really. And it was interesting for me to sort of reflect on this and our commission too, the linking of the political commitment and the financing. Because I think, President Kikwete, I think, said it extremely well, really. That at the end of the day, I think these are often a head of state issues. And my experiences over the years working in a number of countries trying to encourage and persuade ministers of finance to spend more money on health, I think one thing we need to reflect on, that a lot of ministers of finance don't like spending money on health. And I think one of our problems is related to a lot of these issues, is there is this realization that to some extent spending money on health and social care does feel like a bottomless pit, because we keep spending more and more and more money on it. Now that sounds like a bad thing, but it's what societies want. I mean, this is, I think, an absolutely key point. And the United Nations did a big survey at the beginning of last year asking people what they wanted to see their governments spend more money on and what was their biggest issue. And admittedly, this was at the beginning of the pandemic, but I still think it holds. Access to healthcare came top by miles. But it is a problem for us that, that if we trying to explain to ministers of ministers of finance why we need more funding, we've got to do a much better job at, persuading that we are spending money more efficiently. So I think these very, very big issues, all countries are grappling with them, and the health and social care debate is obviously absolutely enormous. It's a hot topic here, it's a hot topic in Japan and Korea. This is really the forefront of these things, and I think very important to recognize that there are big technical aspects involved in this, but yet again, coming back to this point, these things are very, very political as well, and how important it is to broaden these debates out to the whole of society, that we come up with rational and fair allocations of public resources. So I can't thank our panel enough for the excellent discussions. I think the two segue together very, very nicely there, and very keen that we continue the debate, and that hopefully through our commission that we will be having discussions with heads of state and ministers of finance about where to prioritise, and some of these issues will definitely come up about prioritising primary care and spending on these areas, and not neglecting the NCDs as you move into the UHC era.